This lecture will cover the care of patients with heart failure. Heart failure is a clinical syndrome that occurs as a result of the ventricle's inability to either fill with blood or pump enough blood out to meet the body's needs. It can seriously affect the quality of a person's life and can also bring about death. It is most commonly caused by coronary artery disease, myocardial infarction, can also be caused by cardiomyopathy, valvular heart disease, and hypertension. The incidence is growing in the U.S. With the older adult population and growing and people living longer. Heart failure is the most common reason for a hospital admission in the older adults. Statistics recently say that 1 in 100 people will develop heart failure. Readmission rates are very high, and half the people diagnosed will die within the first 5 years. So I want you to think of this analogy. Heart failure is like a dam in a river. And I've talked about this a lot with the cardiovascular system. It's plumbing. It's all about pressure and flow. So if you have a river without the dam, the river flows freely and you've got a normal cardiovascular system, blood flows freely. If you have a river and you put a dam in it, the river backs up behind the dam and becomes a lake, a stagnant lake. In heart failure, the ineffective ventricle acts like a dam and the blood backs up behind it. As with a river, too much water building up behind the dam will flood the riverbank and form a lake. In the heart, too much blood backed up behind the ventricle causes flooding, and in this case, edema. If it's on the left side of the heart, it causes pulmonary congestion and edema. And if it's on the right side of the heart, it causes peripheral congestion and edema. There are a lot of ways to classify heart failure pathophysiologically. But interestingly enough, both of them have to do with our old friend, the ejection fraction. How much of the blood that is in the ventricle is being ejected as cardiac output. So you can either have systolic failure or diastolic failure. Systolic failure, as you remember, systole is contraction and ejection, so it's an ejection dysfunction. It's the contractile problem, and the ventricle is unable to generate enough force to pump the blood out. Diastolic failure is a relaxation dysfunction because remember, diastole is when the heart rests and fills. So in diastolic failure, the ventricle can't relax and fill, and if you don't have enough blood filling, then you don't have enough to eject out. You can have a combination of both of these, and either of these can be on the right side of the heart or the left side of the heart or both. So in terms of ejection fraction, how do we know what somebody's ejection fraction is? Well, it can be determined with echocardiography, which is like an ultrasound of the heart, or it can be done through left heart catheterization. And determining the ejection fraction is a key feature of determining the correct treatment in heart failure. Another way to classify heart failure is by looking at right-sided heart failure versus left-sided heart failure. That's probably something that you're more familiar with. So both ventricles, if you think about it, must be able to pump out the same amount of blood at the same time for the system to work. If you want everything to flow smoothly, the cardiac output from the right ventricle and the cardiac output from the left ventricle have to be pretty much equivalent. or else something somewhere will back up. The left ventricle will take that side first. It must generate enough force to overcome the pressure in the aorta, which we call afterload. Your diastolic blood pressure reflects this. It's peripheral vascular resistance. So you have the pressure in your aorta and your arteries. They provide peripheral vascular resistance. And again, that's what we call afterload. And that's what the left side of the heart has to pump against. It generates a systolic pressure great enough to overcome the diastolic pressure and eject that blood through the aortic valve. If this doesn't happen and enough blood does not get ejected, the blood backs up into the left ventricle, back into the left atrium, and eventually back up into the pulmonary vasculature, which, as you recall, is a low pressure system. So increased fluid in the pulmonary vasculature increases the pressure in this low pressure system, and high pressure causes fluid movement from the capillaries into the interstitium of the alveoli, and that is pulmonary edema. So you've got a dam, and you've got the blood backing up in back of the dam, and eventually the pressure gets so great the blood jumps its banks. It goes out of the veins into the capillary, into the interstitium and the alveoli, and becomes pulmonary edema. So anything that causes increased afterload can predispose someone to left ventricular failure. The one thing that comes to mind is hypertension, because the heart has to pump harder to overcome a higher pressure. Also, anything that damages the heart muscle, like myocardial infarction or hypoxemia from coronary artery disease, that can also contribute to left ventricular failure because the muscle's not strong enough to increase the diastolic pressure and get that blood out. So that's what happens on the left side. And so the net result of this is you have reduced gas exchange because you've got fluid in your alveoli, pulmonary edema, and that causes hypoxemia and dyspnea. Because remember, we've got three determinants of giving oxygen or delivering oxygen to our tissues. We've got the air we breathe in, the circulation that makes the blood travel around, and the hemoglobin that's hanging onto the oxygen. We're going to take the hemoglobin out of this equation. We're going to assume that they're inhaling enough oxygen, but now that oxygen is not able to diffuse into the blood because it has to pass through all that pulmonary edema in each individual little alveolus. And so that's why you get hypoxemia and dyspnea. So let's move to the right side. The right side must also generate enough pressure to pump blood into the vascular system that it pumps it into, which is the pulmonary vascular system, and it is usually a low pressure system. It also is being filled constantly from the venous side of the body, lots and lots of blood volume, and that blood volume that's coming back to the right atria, venous return, that's what we call preload. So the right ventricle must take that preload and generate enough pressure to pump the blood into the pulmonary vasculature. So how do you get right ventricular failure if the pulmonary vasculature is normally a very low pressure system? Well, honestly, the most common cause of right ventricular failure is left ventricular failure. So let's go back to the left side where we left off, and there is fluid in the alveoli, fluid in the interstitium. There is high pressure in that pulmonary capillary network, high pressure in the pulmonary vasculature because of all the blood that's backed up from the left side. The right ventricle has to eject into that, and it's now pumping against an increased pressure system. And so it has to work harder and it hypertrophies. And so blood then backs up from the right ventricle into the left ventricle, or excuse me, the right ventricle into the right atrium, and eventually into the systemic vasculature. So what you have then is you've got a dam that has not only overflowed its banks into your alveoli in the lungs, but it's also flooded the whole county. And now it's backed up into the right side and the systemic vasculature, and the right ventricle has failed. Another cause of right ventricular failure is cor pulmonale, and that is right ventricular failure from increased pulmonary pressures due to pulmonary hypertension. Now we talked about this in the respiratory thing. I didn't give you too much detail. There's a lot of reasons for pulmonary hypertension. Primary pulmonary hypertension, nobody really understands why it exists. And then there's pulmonary hypertension for other reasons. But it's the same idea. The back pressure, the increased pressure in that pulmonary vasculature makes the right ventricle have to work harder, and eventually it fails. So the bottom line then is in right ventricular failure, what we see is increased venous pressures in the peripheral venous circulation, and then we get systemic edema, and eventually congestion in the portal circulation, and really in all of the vascular beds of the body. This table lists some different causes of left ventricular failure. Aortic stenosis, which is when the aortic valve won't open fully. So of course the left ventricle has to increase the pressure to pump against it to get adequate cardiac output out. Cardiomyopathy, there's an increased workload on the heart because you have impaired contractility of the cardiac muscle, and so that's the muscle doesn't contract efficiently and therefore doesn't eject enough blood. A coarctation of the aorta, again, it's another restricted outflow. You don't see that a whole lot. Hypertension, you do see a lot because there's that increased resistance to left ventricular ejection because of the elevated systemic vascular pressure. A heart muscle infection, you get increased workload from the damaged myocardium. You'll see that in endocarditis, and sometimes that'll actually be the cause of cardiomyopathy too. You can have viral cardiomyopathy. Myocardial infarction, of course, you have impaired contractility because of the damage from the infarction. And then mitral regurg is when the blood doesn't effectively empty because there's backflow because the valve stays open. So a lot of different reasons that you can have left ventricular failure, some more common than others. This slide lists causes of right ventricular failure. An atrial septal defect is a congenital condition that is usually fixed in childhood. Sometimes it's not, and it can cause right ventricular failure. Cor pulmonale I just discussed. Left-sided heart failure can back up and become right-sided heart failure. Pulmonary hypertension we just talked about, and then also a problem with your pulmonary valve because again your right ventricle is having to pump against the increased pressure because the valve won't open. And so those are a lot of different causes, but the main cause that you will see is as a result of left-sided heart failure. So I don't want you to think about heart failure as just one static thing. It is a chronic illness and it it exists on a continuum. And along that continuum, you get acute exacerbations, and then it kind of calms down to a steady state, and another acute exacerbation, and it calms down into a steady state. And as the disease progresses and becomes more chronic, the signs and symptoms worsen over time. So acutely, when you have an acute exacerbation, what you will see, of course, is very sudden, severe fluid congestion in the alveoli, and this is life-threatening. It occurs when the myocardium is severely stressed because you have had, let's say, a myocardial infarction and there's some damage. You've had a myocardial infarction and blown out a chordae tendineae to one of your valves. You have had a big fluid overload. You've got a virus and your ventricle is not able to meet the metabolic demands of your that your body's demanding to fight the virus. Lots of different reasons. But your myocardium is severely stressed for whatever reason, and this is causing the left ventricle to fail. Complications can include dysrhythmias and also cardiac arrest. And then underneath there, then you see what I said earlier, which is the chronic progressive disorder, waxes and wanes with acute exacerbations, come back to the chronic, signs and symptoms worsen over time, and then eventually you get to end-stage disease. Your body is just a beautifully designed machine, and it has some intricate feedback mechanisms such that when one part of the body fails, another part of the body tries to pick up the load and compensate for that failure. In heart failure, what happens is the sympathetic nervous system releases epinephrine and norepinephrine to try to increase the heart rate, because you've got a decreased cardiac output, and remember, cardiac output is heart rate times stroke volume, and so it's trying to increase the heart rate to increase the cardiac output. So the design here is to make things better, to increase the cardiac output, but really it can make the heart failure worse, because what happens is that increased heart rate does increase the cardiac output, but it also increases the oxygen needs of the heart. So it increases cardiac workload at a time when the heart cannot support any more workload. And so that's not necessarily a good thing. Then, in response to decreased renal blood flow, because decreased cardiac output means decreased renal blood flow, the kidneys release renin. And that starts the whole renin, angiotensin, aldosterone system, plus the pituitary releases ADH. So the net result here is to conserve water, because cardiac output is heart rate times stroke volume. They want to increase the volume, and that backfires too, because the net result is to conserve the water, which adds to the fluid retention, which is already present in heart failure, because you've got all that fluid backing up due to the pump failure and the dam in the system, if you will. Compensation may produce temporary relief in the symptoms, but it also increases the workload of the heart eventually, whether through increased oxygen demands through increased heart rate, or increased oxygen demands through an increased fluid volume. And that further contributes to the failure and really can become a downward spiral. And so over time, what happens is, as the heart responds to this increased workload, you get dilated ventricles and you get ventricular hypertrophy. It's a muscle, remember, and if it's working harder, it hypertrophies. And when it hypertrophies, it becomes less effective as a muscle. And so the thing just remodels, and as the remodeling takes place, the pumping action is less effective, and things just get worse and worse. There are a lot of factors that precipitate heart failure or can precipitate an acute exacerbation of otherwise stable heart failure. Anemia is one of them, because remember the triad here: the oxygenation, the perfusion, and the oxygen carrying capacity of the blood. And so if you become severely anemic, that is something that your heart can't compensate it for if it's already damaged. A systemic infection can put increased workload on the heart because it increases the metabolic demand of the heart to fight the infection, and that is something that a heart which is damaged cannot compensate for. Fluid overload, if you've got too much fluid coming back to the right side of the heart, that can tip you over into failure. A pulmonary embolus can do this because remember that's a VQ mismatch, a ventilation perfusion mismatch, and you are not getting good perfusion to the areas that are ventilated. Therefore, you're hypoxemic and your heart is having to work harder to pump more blood, and it's not able to compensate for that. Thyroid disorders increase your metabolism. And it's the same effect as if you had an infection. It just cannot keep up with that increased metabolism. Dysrhythmias, especially tachydysrhythmias. So if you recall back when we were talking about anatomy and physiology, systole is about 4/10 of a second. It's always the same. Contraction always takes the same amount of time. Diastole is variable. So whatever you're not doing in systole, your heart has time to fill. If your heart is beating 60 times a minute, your heart has plenty of time to rest and fill. If your heart is beating 160 times a minute, there is very little diastolic time there. There is no time for the heart to relax and fill, and so your cardiac output is going to decrease, and eventually your heart will fail. Pericarditis, myocarditis, endocarditis, these are the infections in the heart muscle that I was talking about earlier, and those can decrease the contractility of the heart muscle. A thiamine deficiency, another problem with the the heart muscle, and with anemia as well. Chronic pulmonary disease, that is something that if you've got heart failure already and you've also got chronic pulmonary disease and you have an exacerbation of your pulmonary disease where you're not getting enough oxygen in, your heart rate is not going to be, your heart is not going to be able to generate enough extra work to overcome that sudden decrease in oxygen that comes from an exacerbation of COPD or asthma or whatever. And then also just physical, emotional, environmental stress, because again, that will set off your sympathetic nervous system and increase the metabolic demands on the heart, and a damaged heart cannot meet those increased metabolic needs. Thinking about caring for older adults, the incidence of hospital admission for heart failure is growing in the US because our population is aging. And aging changes can contribute to this as well as other chronic diseases, because recall what happens to your vasculature as you age. Your arteries get stiff, your myocardial muscle gets just a little bit less strong, venous system, the valves become a little bit more incompetent, so you've got more venous pooling. So there's a lot of different reasons why just normal age-related changes can contribute to some of this. Older adults have less chronic reserve, and so they are at risk for heart failure with really any condition that increases oxygen demand. So as we talked about in previous slides, anemia, infections, anything that's going to increase the metabolic rate and the oxygen demand can tip an otherwise stable heart failure over and into an exacerbation. Another thing to think about is renal blood flow. So renal blood flow decreases with aging. So you need to be particularly aware of urine output in older adults, because a loss of perfusion in heart failure can really increase the risk for renal insufficiency and renal failure. And so your renal blood flow is less anyway, and then you're tipped over into failure and the renal blood flow becomes even less than that. And how do you know that? You know that because of a decrease in urine output. So keep your eye on that urine output in older adults. And then in terms of cultural care, African Americans have a higher incidence of congestive heart failure and have higher mortality rates than their Caucasian counterparts do. So if you're assessing somebody, what are you going to see with left heart failure? Well, you're going to see an increased respiratory rate. Sometimes you'll get accessory muscle use, severe dyspnea, orthopnea. They have to sit up to breathe. Anxiety, restlessness. It's very scary to be breathless in this way. You'll hear crackles and wheezes because you'll have fluid in the alveoli. They get a cough with very frothy sputum that will be pink or have little tinges of blood in it. They will be pale. Sometimes you'll see some circummoral cyanosis, and they'll get cold, clammy skin. Their mucous membranes will also be pale from hypoxemia. Diagnostic tests that they will do, they'll do a chest x-ray. Sometimes they'll do blood gases, not always, an EKG for sure, and sometimes hemodynamic monitoring, which is if they're in really severe heart failure, a big long catheter that goes into the pulmonary artery, and they can measure the pulmonary artery pressures and the cardiac output from there. Therapy, oxygen for sure, either high or semi-Fowler's. Never put these people flat. They need bed rest, IV drugs, morphine, diuretics, inotropic agents, vasodilators, anything that they can do to decrease that workload on the heart. They will need really frequent vital signs. And again, if they have a hemodynamic monitoring, they'll get frequent pulmonary artery pressures measured. Urine output, hugely important here. To monitor for renal insufficiency and also to monitor to see if your diuretics are working. Daily weights, again, hugely important to make sure that you're getting the fluid off and your diuretics are working. And ultimately, you need to treat the underlying cause. So if this was a problem because of anemia, you got to treat the anemia. If this was a problem because of an infection or sepsis, you got to treat the infection or sepsis. Whatever the issue is, COPD exacerbation, treat the underlying cause. And so the priority nursing diagnoses here, of course, are impaired gas exchange, decreased cardiac output, and excess fluid volume. So this slide talks about the New York Heart Association classifying heart failure in terms of exercise tolerance. And it's nothing that I don't think anybody's ever going to ask you this on a test, but I think it's useful for you to know because it's used as a guide for treatment. And so as you're reading someone's medical record, if you see that they're New York Heart Association class 2, then that will make sense to you because you know they've been classified in terms of their activity tolerance. And so class 1, ordinary physical activity, no symptoms, walking around, you'd never know they had a problem. Class 2, dyspnea with long distance walking, climbing 2 flights of stairs, or strenuous activity. So starting to progress a little bit, but probably doesn't affect their activities of daily living too much. Class 3, dyspnea and fatigue with short distance walking or climbing 1 flight of stairs. So that could start to impinge on their activities of daily living, especially getting out of the house, shopping, doing laundry if your laundry is in the basement, or whatever your daily activities tend to be. And then class 4 is dyspnea at rest or with very little activity at all. And so it's the progression of exercise tolerance that is used here to guide treatment. This slide compares and contrasts the signs and symptoms of right-sided heart failure versus left-sided heart failure on a chronic basis. You've seen this in pathophysiology. You've seen this in physical assessment. You're seeing it again in med surg. That should give you a little clue that this is important stuff for you to remember. You need to know this stuff. So on the right side, the problems that we're going to talk about are all due to the backing up of the blood in the systemic vasculature. So tachycardia, jugular venous distension, fatigue, dependent peripheral edema, and splenomegaly and hepatomegaly. It's just when your spleen and your liver become engorged with all that extra blood. GI pain, nausea, and vomiting. Again, your GI system vasculature becomes engorged with all of that extra blood. Weakness, nocturia. Nocturia happens because of the dependent peripheral edema and all the engorgement of all of these vessels. Because remember, we talked about how your capillary system is just an amazing, vast network that you can just stash a whole bunch of blood volume there. And that's what happens during the day. Gravity takes over, your legs are hanging down, your arms are hanging down, and lots of blood is stored in that capillary network. Then you go to bed and your body is relatively horizontal. There's no more pressure from gravity pulling on that. And so all the blood from those little capillary beds gets dumped back into your venous system, back through your kidneys, creates more urine, and you get nocturia. Ascites is again from back pressure. There is so much back pressure that it actually spills out into your peritoneal cavities. The fluid does, sort of like, I'll think of it as pulmonary edema, only except in your pleural cavity. And of course, weight gain from all the excess fluid. So contrast that with left heart failure. Yes, you have tachycardia in both places. Left-sided, you'll get tachypnea because you're hypoxemic. Dyspnea on exertion because you're hypoxemic. Orthopnea because you're hypoxemic. Paroxysmal nocturnal dyspnea, that's when you wake up in the middle of the night panicking and dyspneic. That dry hacking cough, especially when they're supine because of the pulmonary edema. You'll have crackles and wheezes because of the water the edema in the alveoli. And then sometimes you'll get Cheyne-Stokes respirations, but that's a real end stage sort of thing. And so if you just look at this with a completely common sense approach, think congestion in the systemic vasculature, right-sided heart failure, congestion in the pulmonary vasculature, left-sided heart failure, and that'll help you reason out the difference between the symptoms of each kind of failure. So in chronic heart failure, they will follow people with a few different kinds of tests than we talked about with acute heart failure. The history and physical is really important, and because it's really important to see how are they living their lives, what is their activity tolerance like, what kind of edema have you got going on, how is their breathing, are they using their accessory muscles, lots and lots of good data you can pick up in the H&P. An ECG, of course, and a chest x-ray to check for pulmonary edema. They'll do echocardiograms. Sometimes they'll do stress tests to check for exercise tolerance and try to get people into a cardiac rehab program. Angiography may or may not be useful, as may nuclear medicine studies. Labs that are important, CBC, you really need to make sure these people aren't anemic, because then that just causes a whole host of other problems. BNP is very important. It has to do with the stretch of the cardiac muscle, and if indeed the muscle stretches, your BNP gets higher, and you can look at that lab and look at the value for the severity of the ventricular dysfunction. BMP, basic metabolic panel, that'll give you a good idea of what's going on with their electrolytes and their renal function, because remember, renal function is a big deal here. Lipids, because a lot of times coronary artery disease is a problem here, so controlling lipid disorders is a big deal. ABGs sometimes, but not usually. And in terms of UA, I think that you can look at it and see, well, are they spilling proteins? So maybe we've got some renal dysfunction, and how concentrated is the urine, those kinds of things. But it's really the CBC, the BNP, and the BMP, and the lipids. Those are the big blood studies that you would do. Sleep studies sometimes are important to make sure that people don't have sleep apnea, and to correct that, because that can also cause increased cardiac workload. And then, of course, if they're hospitalized, hemodynamic monitoring. Oh, complications. There are so many. Hepatomegaly and splenomegaly, so you can really get some liver and spleen damage with a lot of chronic heart failure. You can get pleural effusions because of the long-standing pulmonary edema, and then you get fluid leaking out into your pleural space. You can get left ventricular thrombus or right ventricular, either way, if you have stagnant blood there, and then emboli can shoot off from that and cause a stroke. And then, of course, cardiogenic shock is when you have just complete pump failure. Therapy, or at least non-invasive therapy, is to treat whatever the underlying cause of the heart failure is. And so if it's a myocardial issue, they do inotropic drugs, they give oxygen, sodium and fluid restriction to try to decrease the preload. Definitely have individualized activity plans to try to increase their exercise tolerance, and daily weight is an absolute must, because it's so important to get on fluid retention early so that you don't have a big dangerous exacerbation. Invasive therapies that they can use if the problem is not a muscular problem but is a heart rate problem or a dysrhythmia problem. They can put in a pacemaker or an implantable defibrillator. If they're really in cardiogenic shock and need assist, you can put in an intra-aortic balloon pump or a left ventricular assist device. That is big time ICU stuff, nothing you need to worry about. They can also do surgery. Coronary artery bypass graft can help with reperfusion. They can do valve repair or replacement if indeed it is a valvular issue that's causing the heart to fail. And then there's also a transplant. Quite often people with cardiomyopathy will get a transplant. The priority nursing diagnoses here are impaired gas exchange, decreased cardiac output, excess fluid volume, and also activity intolerance. Goals of treatment for heart failure, both in terms of medical care and nursing care: to reduce the oxygen demand and the cardiac workload. Some of that is reducing the afterload. Some of that has to do with lifestyle changes and building up exercise tolerance. They can strengthen the pumping action of the heart, strengthening its inotropic effect, and that is mostly from a drug point of view. relieving venous congestion. There are medications that can do that, and there are activity and lifestyle changes that can do that. And minimizing sodium and water retention, same thing. Drug solutions and also nursing solutions to help them with lifestyle changes. And these last two will both reduce the preload. This slide goes over medications for heart failure. I am not going to try to go over all of this. I will refer you back to your pharmacology class, but these are medications that you will give very, very frequently. And it's important that you're familiar with these medications, with their side effects and their nursing implications. So we'll start with, and these are in alphabetical order on this slide, not necessarily in order of importance or use. So we'll start with ACE inhibitors, angiotensin converting enzyme inhibitors, which works on the renin-angiotensin system. So examples would be captopril, enalapril, lisinopril. And the nursing implications here, of course, are checking the apical pulse and blood pressure before each dose and holding or calling if indeed it's below the parameters. Orthostatic hypotension, huge with these, really big deal. Have them take their first dose at night to adjust their BP because you don't want them taking it in the morning and going out and then falling flat because their BP drops too quickly. And then finally, they have that cough, that really hacky kind of cough that comes because angiotensin converting enzyme is in the lungs, and so that causes a cough. And sometimes it can be helped if you change drugs within the drug class. Sometimes you have to just discontinue that drug class and try another drug class. Angiotensin 2 receptor blockers, or ARBs, ARBs as they are known. Losartan, valsartan, again, check the apical pulse and the BP. It's very important. Orthostatic hypotension is very important. You can get a rash and a swelling in your throat from these drugs, and so that's really important to watch out for. You can also get some dysrhythmias for that, so they would need to watch out for some palpitations or irregular heartbeat. Beta blockers, examples are metoprolol, carvedilol. Again, apical pulse and blood pressure, there is a theme here. And then take their pulse daily, their blood pressure weekly once they're at home and are on continued therapy with this. Some beta blockers are not cardioselective and can cause an asthma exacerbation, so be careful with that. Loop diuretics is furosemide, spironolactone, hydrochlorothiazide, checking your pulse and blood pressure, but orthostatic hypotension, really a big thing with diuretics. So teach them how to get up slowly and teach them about monitoring their electrolytes and either taking their supplements or making sure they're getting enough potassium in their diet. Teaching regarding the hyper or hypokalemia, very important with these. Inotropic agents, dopamine and dobutamine, these are things that you will probably only see in the ICU, so this is not quite as important for you as the other ones are. These support blood pressure, but you need to take care to really monitor renal blood flow because these are drugs that can rob renal blood flow to maintain cardiac and cerebral perfusion, and you can get some real problems with those. Inotropic agents, digoxin and milrinone. Digoxin is the one you'll probably see most. Again, checking the pulse and holding if it's below parameters. Really monitoring electrolyte levels. Hypokalemia and dig toxicity just go hand in hand. And so they need to make sure to know the signs and symptoms of toxicity so that they can come in and get that checked out. And then vasodilators, isosorbide and hydralazine. These are drugs that are vasoactive directly and will decrease the blood pressure and therefore decrease the work on the heart by decreasing the afterload. So apical pulse and blood pressure is important, orthostatic hypotension is important, and initially they'll get a headache, but then usually it'll go away. Isosorbide is a nitrate. Hydralazine isn't. So anyway, a whole host of drugs here, and it is sometimes a bit of a dance for the patient and their provider to figure out what mix of drugs meets how low they can get the blood pressure to go to maximize the cardiac output without getting the side effects of the orthostatic hypotension. How much is too much in terms of lowering the preload and the afterload? It's just really a balancing act. The Joint Commission has core measures for heart failure for quality care. The first one on the list is discharge instructions. These need to be very specific in terms of medication, diet, activity, what to look for in terms of side effects, and to decide whether or not you are developing an acute exacerbation. Evaluation of left ventricular function, which, as I mentioned earlier, can be done as an outpatient with a 2D echo, or can be done as an inpatient with a cardiac cath. Medication-wise, they recommend an ACE inhibitor and an angiotensin receptor blocker for left ventricular systolic dysfunction. And then, of course, always smoking cessation and counseling if needed. For nursing management, there's a care plan in your book that you can look at. Um, Heart failure is a chronic disease that people just need to learn to manage. And that is our job as nurses to help them learn to manage this at home. Management includes, as I mentioned with the discharge teaching, medication, activity, diet. Uh, the rest activity balance is so important because people just don't think about this, and they don't understand the need for spacing out your activities and for resting after meals and all these things that can help reduce the workload of your heart. Dietary changes, the low sodium, low cholesterol diets, where to find the recipes, eating small meals, when do you eat, spacing your activities around your meals, that sort of thing. Medication administration, the side effects to look for, how to get the most from your meds, how do you get the most fluid off with that diuretic. You know, if you take your diuretic and you lay down for a while early in the morning, hang out, get that renal blood flow going, take the force of gravity away, that diuretic is going to work a whole lot better than if you take it and get up and go off walking. So just a few little tweaks about how to get the most from your medication can really make a difference. Infection prevention, people do not think about this, but one thing can tip you over into heart failure really quickly is an infection because it puts increased metabolic demands on your heart that your heart can't compensate for. So teaching hand hygiene and avoiding crowds and avoiding sick grandchildren and all those sorts of things. And then any other kinds of lifestyle modifications that they can make within their exercise tolerance or to increase their exercise tolerance. These are all things that we can help with. I'll run through cardiac or cardiomyopathy real quickly. It's a group of diseases that affect the structure or the function of the heart. You have a picture of your normal heart here, and then your dilated cardiomyopathy, which is when your ventricles become really, really enlarged. And this happens sometimes as a side effect of chemotherapy. It happens with alcohol abuse, infection, inflammation, poor nutrition, a lot of other reasons, and this always progresses to heart failure. Hypertrophic cardiomyopathy is excessive growth of the left ventricular muscle. This can be hereditary. This can happen because of long-standing hypertension, and this can actually is implicated in sudden death. And then there's restrictive cardiomyopathy, which is when your ventricles get stiff and it inhibits ventricular filling. And so this is a connective tissue disease, and it happens in things like sarcoidosis, and this will progress to right ventricular failure. So these are things that you may or may not see, but I just kind of wanted to go through them with you. So once again, cardiomyopathy, a group of diseases that affect the structure or function of the heart. Um, Signs and symptoms are pretty much heart failure and dysrhythmias, activity intolerance, things that you're very familiar with. Diagnosis, again, things that you're familiar with. The medical treatment, very much like the treatment of any kind of heart failure. If it's really severe, they will put in a left ventricular assist device or do a transplant. And this is a picture of an LVAD or a left ventricular assist device. It's basically just a little mechanical ventricle that helps your left ventricle pump out more blood. When I was starting out in nursing in the 1980s, we started using LVADs, and the machinery that went with them filled an entire room. And now it can be implanted and worn on your belt. Pretty cool. And a notable person who has an LVAD is former Vice President Dick Cheney. He had an LVAD for quite some time before he had a transplant. This flower is called foxglove or the digitalis plant. And digitalis can be very effective in treating certain kinds of cardiac disorders, both heart failure and some different tachyarrhythmias, but its therapeutic range is very narrow. A therapeutic dose is only about a third less than the dose that will induce toxicity. So, and it's measured in amounts less than a milligram. And so very, very narrow therapeutic range. And you have to be aware of the signs and symptoms of digitalis toxicity, and you have to teach people. So they get these yellow-green halos around lights, visual changes that make them feel funny, classic nausea, vomiting, diarrhea, confusion. Physiologic changes resulting from age, electrolyte imbalances, particularly hypokalemia or hypercalcemia, renal impairment, metabolic disturbances, and certain heart conditions can predispose people to digitalis toxicity. And so if you've got people, let's say for instance, taking diuretics that are potassium wasting and they're not replacing the potassium, or you have people who have renal issues or metabolic issues, you really have to watch them very carefully. So let's end this with a case study. So part one, we have a 66-year-old man. He has a family history of heart disease, and he's seen in the primary care provider's office. He's had hypertension for 10 years. He takes captopril daily, and his baseline data from a previous visit are blood pressure of 122/78, heart rate 80, respiratory rate 18. He's 5'6" and weighs 170 pounds, so a little overweight. He states that he's been short of breath during his daily 2-mile walk and has been using 2 pillows at night to sleep. As he talks, the provider notices an intermittent dry cough. Vital signs today are blood pressure 140/86, heart rate 106, respiratory rate 26. He weighs 178 pounds and he has bilateral crackles in his lung bases. As we look at this gentleman, what signs and symptoms of heart failure does he have? He has dyspnea, shortness of breath. He has two-pillow orthopnea. He has a dry cough. He's tachycardic. He's tachypnic, and he has bilateral crackles. So then the question is, do these signs and symptoms represent what sounds like right-sided or left-sided heart failure? I think left-sided heart failure by the findings, because it sounds like to me this is failure that is backing up pressure and fluid into the pulmonary vasculature, the orthopnea, the shortness of breath, and the dry cough, the crackles, and the tachypnea. Why are each of these signs and symptoms occurring? Well, he's short of breath because he has fluid in his lungs, and that's impairing his gas exchange. He's orthopnic because laying down flat increases the fluid accumulation in the lungs, and that causes more dyspnea. The cough is from the fluid in the lungs irritating the mucosal lining. Tachycardia, sympathetic nervous system compensating to increase the cardiac output. Tachypnea, sympathetic nervous system compensating to increase oxygenation. The crackles, again, the fluid in the alveoli. So then, how do the pillows help him sleep? Well, these two pillows help prevent him or help him to sleep by keeping him in a semi-upright position, allowing gravity to decrease the fluid accumulation in the entire lung fields. It keeps it down in the bases, and so the areas in the top lung fields aren't congested and can have better gas exchange. And finally, what healthcare team members might collaborate on his care? Well, the provider, for sure, and if it's a primary care doc, maybe a cardiologist. May need a case manager if he needs other services. Nurses, a dietitian, for sure. Occupational and physical therapy may help with activity prescriptions. A pharmacist, because for sure they're going to need medication. And maybe a social worker, depending on, again, what kind of services he needs, and really probably more in the future because he's not in too bad a shape right now. So the provider orders a chest x-ray and it shows an enlarged heart, which is also called cardiomegaly. Why is his heart enlarged? Well, the heart enlarges to compensate for the strain caused by the increased peripheral vascular resistance from the hypertension to try to maintain cardiac output. So it's just like any other muscle. When it has to work harder, it gets bigger. What is the significance of an enlarged heart? Well, an enlarged heart requires more oxygen, which often cannot be supplied in heart failure. So it's one of those compensatory mechanisms that in the end actually makes things worse instead of better. So after the visit and he's getting ready to go home, the provider tells him he needs to continue his ACE inhibitor. He adds a diuretic and he prescribes a 2-gram sodium diet. So why is the ACE inhibitor continued? Well, ACE inhibitors are really good drugs in congestive heart failure. It causes vasodilation, and so that helps reduce peripheral vascular resistance, which, remember, decreases the afterload, decreases what the heart is pumping against, decreases the workload of the heart. This improves or can improve cardiac function and prevent that remodeling that we talked about that makes the left ventricle more damaged. The ACE inhibitor then reduces afterload instead of preload. Why is the diuretic prescribed? Well, the diuretic will decrease fluid volume, which decreases preload and decreases cardiac workload. What lab tests would be monitored with the diuretic? Well, potassium, of course, would need to be monitored because the diuretics can either be potassium sparing or potassium wasting. So either way, you need to watch potassium. Why is a 2-gram sodium diet prescribed? A low sodium diet will reduce water retention, which will in turn decrease preload, which will in turn decrease cardiac workload. And then the final question is, what is the overall goal of the treatment prescribed? Well, the overall goal is to decrease the workload of the heart. And so that will hopefully increase cardiac efficiency. And what they do is they try to optimize the preload and the afterload. Remember, I said this is a balancing act. And so they try to find that sweet spot. What is the optimal balance between decreasing the preload, decreasing the afterload, and then therefore decreasing the cardiac workload and the progression of chronic heart failure and improving survival? So the primary care provider talks about the medical prescriptions, and then the nurse meets with the patient to help. What patient-centered information should be included in education? Well, you need to assess the knowledge base and the learning style. Find out what they already know and find out how they learn best. Give information about medications, of course, and that includes why they're taking them, how to get the most out of the meds, what are the side effects, and what precautions to look for. What are the things they need to call about if they think they're getting in trouble. Maybe plan a schedule for the medications to help them understand when to take them in relation to the rest of their life, in relation to meals, in relation to rest, and the medications in relation to each other. An explanation of the diet prescription, find out what the food preferences are, and then also not just involve the patient, but also involve the person who cooks and shops if indeed that is not the patient. What types of foods should be included in this diet? Well, you could give the person a list of high sodium foods and low sodium foods. These can be found in your book. They can be found online. Many resources with the American Heart Association about low sodium diet. One thing you can do for sure is talk about hidden sodium. Teach them how to read labels and give them maybe not just a written list, but a list of resources that they can look for online or in a book in the library, depending on what their preference is. So why does the nurse instruct him to weigh himself daily? Well, the thing about body weight, it is the most sensitive way to measure fluid balance. A daily weight will detect rapid weight gain that indicates fluid retention, and to measure weight loss from a diuretic. So either way, whether you're retaining fluid and gaining weight or losing fluid from treatment, daily weight is the best way to assess this. What specific instructions need to be given for daily weights? Same time of the day, same clothing every time, and same scale every time to ensure accuracy. You know, people will say, well, my scale weighs 2 pounds heavier than the doctor's office scale or whatever. It's not the absolute weight here we're concerned with. It's the change in weight. And so same time, same clothing, same scale will make your weights more reliable and more accurate. And then what are we going to report to the primary care provider about this weight gain? So report greater than 2 pounds in one day or 2 to 3 pounds over the course of 1 to 2 days.